I'm delighted to be here, and I'm a tremendous admirer of the research that's done here. Very important stuff. We did a very small study on overdose, and Amy replicated it with a much larger sample, and boy, I was very glad to see that. Okay, I'm going to talk about what group health has done to try to reduce risks and dose of people using opioids long-term for chronic pain. But I'm going to preface that with some of the rationale for what we've done. So I do have support to Group Health Research Institute from drug companies for some of my research. Misinformation about opioid safety and effectiveness led physicians to shift from conservative to liberal prescribing norms for long-term opioid treatment. So this is a slide that shows some of the recommendations from 1996. So I think it's important to go back to when when opioid prescribing really took off and look at what some of the things that were said back then. So if you look at the statement about overdose, respiratory depression induced by opioids tends to be a short-lived phenomenon. Generally occurs only in the opioid-naive patient and is antagonized by pain. So basically there were signals put out there, information put out there that turned out to be incorrect, put out there with the best of intentions to help patients. But it gave primary care physicians in particular the notion that the things they were concerned about, overdose and addiction, weren't going to be big problems with pain patients. When you look at the industry-supported CME, the claims made were even bolder. So this is from a DVD that was distributed by a drug company called I Got My Life Back. There's no question that our best, strongest pain medicines are the opioids, but these are the same drugs that have a reputation for causing addiction and other terrible things. Now, in fact, the rate of addiction amongst pain patients who are treated by doctors is much less than 1%. They don't wear out, they go on working, they don't have serious medical side effects. These drugs should be used much more often than they are for patients in pain. Then there's a moral claim. We doctors were wrong in thinking that opioids can't be used long-term. They can be, and they should be. It is not acceptable to say, I don't believe in using strong pain medications for chronic pain. We need to stop saying this. Now, it wasn't just drug companies sending out DVDs. There were policy changes made in states, training in medical schools was disseminating some of this kind of information with the best of intentions. It wasn't based on solid research, and it hasn't panned out. The hopeful thing about this is that this sort of information contributed to a very large shift in prescribing. So if disseminating information and changing the norms of physicians regarding what safe and effective practices can increase prescribing, maybe that's part of the answer to shifting back towards more conservative, selective, and cautious prescribing of opioids. You saw the data on what happened during this 12-year or so period when opioids prescribing increased on rates of overdose in Grant's talk. Here are the same slides that show the trends in rates of admission for drug addiction treatment for non-heroin opiates. So in 10 years, we really saw an epidemic levels of treatment for addiction to prescription opioids. That same video that I talked about that made the bold claims for the effectiveness and safety of opioids featured several different patients. And one of the things I'd like you to think about is sometimes we use this frame that there are good patients, that have real pain, and if they don't have risk factors for addiction, it's pretty safe to prescribe opioids to them. And then there's these high-risk patients that are drug seekers, and if we can just sort those out, we aren't going to have a problem. Well, this particular patient is somebody that was featured in a video, sponsored by Purdue Pharma, and she did very well initially. And over time, her dose was escalated a couple times, and then down the road, she ended up in trouble. I wasn't very active. I never really left the house other than to go to work. I couldn't go out in the yard to play with the grandkids or any of those kinds of things. It took the best part of 16 months before I could focus again, before I could stop that craving. If I were still on that medication, I would probably be dead. So I think we need to keep a real open mind. As the previous talk, there's different kinds of patients. There's patients that aren't coming drug seeking. They're coming for relief of pain, but sometimes they end up with an opioid use disorder. By the way, if you want to see this video, it's on YouTube. It was done by Physicians for Responsible Opioid Prescribing. There's a profile of another patient who unfortunately died with an interview with his wife. There's 6 patients that were featured as success stories on a Purdue video. 2 of them dead, and one of them, this person, ended up with an opioid use disorder. So it's a very compelling video. Most patients in primary care who use opioids long-term are using it at lower dose. And, the research is suggesting that, that there are problems, that as you increase dose, the risks increase. In addition to the direct risks, there's the indirect risk. In the last talk, we heard about diversion. Most people who use opioids non-medically get them from friends or a relative, usually for free, and the person who gives it to them has usually gotten them from a single physician. So you can't divorce the diversion problem from the overprescribing problem. And long-term opioid therapy patients receiving higher doses, that's 50 milligrams a day or higher, so moderate to high dose levels, account for about 60% of all the morphine equivalents dispensed for acute or chronic pain. So those higher dose patients, the total amount of drug getting out into the community is heavily influenced by those patients getting a higher dose. You've heard about the relationship to dose with overdose risks. Remember that statement back from the mid-1990s? Nobody would say this now, I don't think, that the risk is less than 1%. Well, now we're starting to have studies that are using DSM-5 criteria to assess what percentage of long-term opioid treatment patients meet DSM-5 criteria for an opioid use disorder. And there's a study by Joe Boscarino that found a rate of a little over 25%. A recent study in Australia found a rate of 20%, and work that we have in progress, the survey we're just finishing up, is finding a rate around a little above 15% for current opioid use disorder, with a little more than half of it in the mild range. So this is a common consequence of treatment, and not a rare consequence, and we really don't know how to sort out very well the patients who are going to develop an addiction problem from those who aren't. We did work with our medical records to identify patients who had problem opioid use documented in the record. And we found, as you might expect, that risk of problem opioid use was strongly related to dose, so same story as overdose. There was a period of time, Aaron and I were talking about this last night, that use of extended release opioids using a time-scheduled dosing was favored. So, well, you're going to get better pain control, and because you aren't using it in PRN, you're less likely to reinforce the patient's less likely to reinforce addictive type behaviors. There's actually no evidence, no solid evidence for this, and Aaron's clinical experience doesn't work very well. When we surveyed patients who said they were using time-scheduled dosing, the ones who said they were using time-scheduled dosing, which generally leads to being on a higher dose, were more likely to report problems like not being able to control their use, being worried about abuse, having others worried about abuse. Okay, so that's the scope of the problem, and a lot of these problems, overdose and abuse, which are a significant part of the problems that patients run into, leaving aside the medical side effects, are dose related. Let's talk a little bit about the effectiveness side. So often you'll hear an argument that goes something like this. Well, there are problems with opioids, but we should use them selectively and carefully because we don't want to deny those patients who are doing, well on this treatment. Well, they're by anecdote. I've got patients on my patient advisory committee who tell me they're doing very well on opioids. So I don't dispute that there are some patients who do well. But typically when you survey chronic opioid therapy patients, and we've surveyed over 2,000 of them back in 2008, most of them report moderate to severe pain. So, this isn't something, the term painkiller is maybe accurate for management of acute pain. It's not accurate for management of chronic pain. Here, this shows the number of activity limitation days reported by patients by dose, and actually the patients, even though the pain levels were fairly comparable, the patients on higher dose were more likely to report high levels of pain-related activity limitation days. See the same thing for unemployment. A large percentage of these patients of the higher dose patients, more than half are not working. So the analogy that's sometimes put out there, like opioids are like insulin for diabetes, not a very accurate analogy. So with that as background, in about 2007, Group Health realized that we were headed in the wrong direction on opioids. And we hired a couple physiatrists. And actually, I worked with a physiatrist, but this particular part of the initiative I didn't have anything to do with. About the same time, Washington State was putting out guidelines, which were very controversial at the time, saying if you have a patient above 120 milligrams a day and they're not doing well, you should consider seeking specialty consultation. Well, there was from certain quarters there was very strong criticism of this. Group Health agreed with that, and we took additional steps to try to alter prescribing norms and expectations regarding high-dose use. And I think our experience, which I'll show you what happened in just a little bit, leads me to a sense of optimism that in settings where you can exert medical staff leadership and take some other relatively simple steps, it's not that difficult to change, to begin to reduce doses prescribed to chronic opioid therapy patients. Well, what did we do at Group Health? The consulting specialists, the physiatrists, and then medical staff leaders. The medical staff leadership is extremely important on this. You're talking about setting norms and expectations. What are the standards of care? So there has to be leadership on this. They recommended more cautious opioid prescribing for chronic pain. The physiatrists did periodic voluntary in-service training sessions on opioid prescribing. You know, kind of a good old-fashioned didactic CME that people say doesn't work. Well, you know, in general, it doesn't work, but sometimes things that change the culture and that change what physicians think is a safe, effective, appropriate practice can make a difference. Coupled with that were reports to physicians and medical directors, clinic medical directors on how many chronic opioid therapy patients each doctor had and how many were on high doses. The physicians with very large numbers on higher doses, you got some guidance from the medical director. Then in 2010, the Washington State updated its guideline, put in, and it was actually put into state law, again, very controversial. A lot of what it called was, you know, straight out of the American Pain Society guidelines, universal precautions, you know, risk management kind of stuff. But it also had the dosing thing. Group Health at that point implemented a major multifaceted risk reduction initiative. So, you know, we said there needs to be a single physician responsible for managing opioids. There needs to be a care plan. There needs to be standardized tools for patient education, treatment agreements available. Those were put into our electronic medical records so they were accessible. We set minimum standards that were risk-based, risk and dose-based for frequency of long-term opioid therapy monitoring, like urine drug screening and check-back visits. And we fixed up our refill ordering processes so they were less chaotic. You just couldn't waltz in on a Friday afternoon and say that your opioids were going to run out over the weekend. I think we required 4 or 5 days advance notice. And some simple, and we went to 28-day period, something that's pretty common now. Some of these simple kinds of things were really helped create, dampen down some of the conflict around this treatment that was happening in our clinics. Now, I got to say about, in contrast to dose reduction, implementing universal precautions is relatively difficult. To implement this, we did kind of the whole 9 yards of quality improvement. We had a guideline, we had a rapid progress improvement workshop that had a lot of people there. I wasn't there, actually. I wasn't permitted to participate in it because I think they thought I was a little too rabid. We had the registry that I told you about earlier, performance measures. There were incentives to do care plans. Medical staff leader was very forward in championing the need for changes. We had an online CME followed by clinic visits, and then we had the consulting specialists, the physiatrists, plus in-clinic gurus that were, you know, helping move things along. So this was really a very successful initiative, but it was a lot of work. And in addition to we'd already done the dose reduction with a much simpler strategy. This was really a major initiative. On care plans, well, let's go back to the dose. So let me show you what happened. So the the advocacy for more cautious opioid prescribing, just from the old style, getting the word out there, changing practice norms, and some guidance from leadership. That started in 2007. And in 2008, we started to see a pretty healthy decline in the percent of patients on high-dose regimens. There was also, Washington State at the same time had this guideline put out there that began to foster discussion about this. It had a much smaller reduction in dose, but still something appeared to be happening. We also were able to achieve a big drop in the percent of patients getting excess days supply, which is an indicator of potentially problematic opioid use. So we were almost 60% lower than our baseline. So how did we get there? We avoided, our clinicians avoided large dose escalations, and they avoided small dose escalations. So I think avoiding dose escalation is not that, the physician just needs to be able to say no with conviction, and given the safety data that's out there now, I don't think that's a hard I don't think that's a hard sell. Physicians need to be able to say, I have a responsibility or safety, and I'm just not comfortable increasing the dose. There isn't really any evidence that you're going to be doing better on a high dose than a low dose. They also had success on smaller tapers, so getting patients from above 120 milligrams to somewhere below 120 milligrams. In the aggregate, we saw that increase relative to the control. Large tapers, moving people from a high dose to a low dose, is not where the action was. There's a caveat here. So we did great stuff on dose reduction. During this same time period, the percent of patients receiving chronic opioid therapy in our health plan and in the community practices, contracted care that were exposed to the new guideline, the prevalence of getting chronic opioid therapy continued to increase. So one concern I have about thinking that dose reduction may be the answer is it doesn't necessarily address the problem of too many people getting this, people getting this treatment who really aren't having decisive benefit from it, but are exposed to risks. On the universal precautions, we had incentives for doing care plans, and we really did very well on that. I think within a year they had care plans developed for almost everybody. How important those were, they tell what the regimen is and who the responsible provider is. They're supposed to have goals in them and all that kind of bells and whistles. I think some of the bells and whistles may not have happened all the time. Now, urine drug screening, and there's been other places, and the VA have done initiatives to increase urine drug screening. I think our results are kind of similar to what people have in other places. So you start out at abysmal, so at the baseline, less than 10% of all chronic opioid therapy patients got a urine drug screen in a year, 15% for high dose patients. And then we were able to, with a lot of effort, we were able to increase that to 50% overall and 65% among the high-dose patients. So that means a third of high-dose patients didn't get a urine drug screen in a year. And we don't really know whether urine drug screens have any benefit for protecting safety anyway. They're hard to interpret. In my mind, I'm not against them, but they're expensive, and they're an invitation for a discussion between the doctor and the patient when you see unexpected results anyway. And some of those discussions could be happening without necessarily doing a test, which is really hard to do. When you say universal precautions, they're not universal. There's a ton of research on that now. So On the efficacy front, long-term opioid therapy patients still report substantial pain and dysfunction. It is just not the case that this is for some patients, this treatment does seem to make a decisive difference, but that is not typical. It's a marginal difference, more typically. It's well established that long-term opioid therapy risks increase with dose. Addiction, as defined by the DSM-5, is a common outcome in these patients, and we've got data that suggests that it probably increases with dose. We'll know more about that when we start analyzing our survey data. There's low-hanging fruit there to begin to ratchet down dose. If you're in a care setting where leadership can change prescribing norms, I think avoiding dose escalation is relatively easy, and if you stick with it, I think there's potential for more patients to be partially tapered than is common wisdom. Universal precautions, I think, doing that is a lot of work. Depending on what the universal precaution is, it may be, you may have variable success in achieving it, and with the exception of checking PDMPs, which is also hard to do, we don't have any research that tells us one way or the other whether they're effective. So I'm not against them. I think if you're going to prescribe this treatment, you got to be really careful. But I don't think the solution to this epidemic lies in universal precautions. So we've done these changes in dosing and universal precautions, and you're going to ask me, well, what effect did it have? And I'm going to say, basically, we don't know yet. We're doing research now with a PCORI grant to see what happens to overdose rates, what happens to motor vehicle accidents, what happens to medically attended injuries, and what happens. We'll be able to compare pain and function and opioid use disorder in patients exposed to the changes in patients not. So that's kind of where we are, and I think I'm guardedly optimistic because I think the key to this is very difficult to interfere with the doctor-patient relationship, and pain does matter to patients. To put out an edict that you're not going to prescribe opioids for chronic pain may not work. But I think there is the potential to educate physicians and to start to shift practice norms, because the data is pretty compelling, in my opinion, already that the harms are much greater than we thought, and I'm kind of a Missouri guy on the benefits. Show me that there's benefits that are commensurate with the harms, and then we should talk about how this, maybe prescribing this treatment to the right people. Well, thanks very much. Glad to be here, and I used up my time. So, okay.
I'm curious as to, while you're doing these studies, is there any work being done?
Oh, great,
okay.
Thank you.
Is there any work being done to sort of supplement with alternative strategies like physical therapy and all the other kinds of things that folks can do outside of using the medication?
This is a really great question. When you start trying to change practice, we've got a study, I'm not the PI, but another person in our center working with federally qualified health centers to kind of tamp down the amount of opioid prescribing. Well, what they want to know is, well, if I'm not going to prescribe opioids, what am I going to do? And I mean, the problem with that question is, A, it assumes that what you're doing already is effective, which it probably isn't for many patients. Not for all patients, but for many patients it's not effective. So I think what people are looking for is a way of closing out a visit that is, acceptable to patients. And I don't think that's going to prevail in the long term. The idea that we're going to have something that has comparable effectiveness to what people think opioids does, which is, kind of something we've imagined up, I think it's not realistic. I think the provider, I think physicians underestimate the importance of their relationship to the patient, their sense of optimism about the future, their ability to convey, yes, you're going through, this is really difficult. Chronic pain is, I wish I could had a differential. I wish I had a diagnosis that I could prescribe a specific treatment. I think clinicians can also be helpful in helping patients explore alternatives. Different things work for different people. Penny Cowan, the director of the American Chronic Pain Association, says managing chronic pain is like driving a car. You got to have 4 wheels, and if 3 of them are flat, you're not going to go anywhere. So somebody who's trying to manage chronic pain just with opioids, that it isn't going to work. So I think clinicians they really need to start thinking this less in I'm going to fix this problem, something they attribute to the patients, and I think that's kind of a shared expectation, and more in terms of, can I help this patient manage this situation? If there is a specific treatment that works, great, but often it's an issue of learning to manage an ongoing problem and getting people through really difficult times in their lives. Thank you very much. Oh, there's one more. Okay.
Have you run into issues around patient reviews of physicians who are changing their prescribing behaviors, and patients are negatively reviewing the physician, and then the physician's compensation is impacted by that? And how have you dealt with it?
I don't have any research on that. I haven't done research on that. That it's certainly something you hear from physicians, that they have patients that complain it's going to negatively. We do surveys, after visits, like I guess everybody's doing those now. So they're concerned that their satisfaction scores are going to be negatively impacted. And I don't, I'm sure it happens. And how big, I tend to think that there's things that happen that get generalized to people in general. If that happens to you, if you have somebody file a complaint with you once, then it's an unpleasant experience, and you may think it happens more often than it does. So I don't know. I think it's a realistic thing. I think we need to avoid creative incentives that reinforce inappropriate opioid prescribing. But I don't know. Is there any research on this, Aaron? It's a big complaint. It's a big complaint.
That especially with patients who'd had their opioids reduced or curtailed or refused, sort of disappointing clinical decisions potentially, how the patient interpreted that decision very much had to do with what they thought their physician was trying to do. So it was interpreted in the framework of the relationship. So even if something was disappointing or not what they wanted at the time, if they felt that it was done for their good, to protect them, to help them in the long run, they were accepting of this disappointing decision. But if they felt like the doctor didn't care or was just applying some universal policy, then that was not as acceptable. So I think it's a complex issue, and that as many different types of humans as there will be different types of reactions. But how we handle these things makes a big difference.
I think this is a signal that it'd be a good idea to hear from the next speaker.